request to the presenters. A few disclaimers, kindly go through them. I would like to draw your attention to our upcoming talks. On Tuesday, we have a talk coming up, Newer Parameters in Cell-Based Counters by Dr. Sukesh Nair from CMC Vellore. And on 1st of September, that is next Thursday, we are having a journal club, which is how to read a pathology paper. It should be taken by Dr. Nikhil Patkar and Dr. Chatterjee from Tata Memorial Hospital. So without any further ado, we would like to start, and I would like to invite Dr. Sachdeva now for starting the slide seminar. Sir, over to you.
Right. Thank you, Dr. Kanchan. So I'll take a few seconds just to share my screen. I hope that is visible now.
Yes, sir. It's visible.
Yeah. Okay. So today we'll have a slide seminar. The topic is approach to pancytopenia, and this is mostly the non-neoplastic disorders. I have 4 cases today, and I'll call out the names of the resident and start discussing the case one by one. So can I just sort of shut down the video now? Oh. No, or let it be. Right. So case 1. So this goes to Dr. Priya Darshini. I'll just read out. It's a 27-year-old male, generalized weakness for 3 months, and a history of 1 unit packed red blood cell transfusion. On examination, the patient just had.
Manu,
Yes.
there is an echo. I do not know how it is coming from where. Others are feeling the echo?
Yes, sir.
Yes, sir. There is an echo.
If anybody has opened 2 appliances, means please shut down your cell phones. But don't open your cell phones. Only the laptop should be working. If you open 2 devices, we have an echo. Over to you, Manu. Thank you. Carry on, Manu.
Right. Okay. Sorry. Just a second. Yeah. And the CBC revealed anemia, mild leukopenia, and thrombocytopenia. So we move to the peripheral blood film. It's again stopped. I'm sorry.
What has stopped, Manu?
The arrow probably is not working for down this slide. Let's see. Yeah. So the peripheral, no, it's still not working. So that's a low power view. And Dr. Priyadarshini, what do you appreciate at this low power? Please, right.
Total leukocyte count reduced and most are lymphocytes and RBC mass reduced.
Right. So 2 things you said correctly. The TLC seems to be reduced, and most of these cells probably are lymphocytes. At this low power, it's a little difficult, but you're correct. RBC is definitely, overall density is reduced. So I'm unable to move with the arrows. That's fine. Yeah. So we move to the next part. And do you appreciate something more?
So in RBC series, cells are normocytic, normochromic.
Okay. The WBCs?
WBCs are
Probably we'll go to the next
lymphocytes.
part. Yeah. So there. Yeah. So here. So now you can actually describe the morphology.
Sir, in RBC, it is normocytic, normochromic RBC. And
Okay. Okay, so there's a sort of mature looking lymphocyte in this slide, and I think about the last lineage, that is platelets.
Platelet reduced, grossly reduced.
Platelets are reduced. Okay, so mostly you said are normocytic, normochromic RBCs. There is slight variation, probably, and slight occasional poikilocyte, sort of a teardrop and elliptocyte, but mostly you are correct. Predominantly, they are normocytic, normochromic. In the next slide, so how do you actually comment upon the size of the RBCs? Is there anything which can help you in this smear?
Compared to lymphocyte, no, small.
Right. So lymphocyte nucleus probably is around 8.5 microns, and that is only true for a non-reactive, sort of a silent looking mature lymphocyte. Once they become reactive, they enlarge in size. So probably the sort of naive and non-reactive mature lymphocyte is around 8.5 microns, and then you can easily compare the RBC size. So true here. And most of them again look normocytic, normochromic, a slight variation in size, maybe a little bit, and maybe occasional poikilocyte. How do you comment on adequacy or number of platelets on, say, this bar? Is there sort of a formula you could uh, recall to assess platelets on smear?
Yes, no
Anyone?
platelet aggregations,
No platelet
clumps,
aggregation.
no platelet clumps.
Anyone? Raina? Dr. Raina? At oil, can you actually?
On peripheral smear, roughly we can say about the quantity of the platelet. If we have to multiply the platelet count we see on 100x into 20,000,
Okay, roughly. I think
roughly.
so. Some people, yeah, like it at 10,000, but some go at 20,000 also. So I'll probably go with 10,000. And so if you see two platelets, three platelets, you can make an average and assess the counts there. So in this smear, we see 90% lymphocytes, only 6 neutrophils, and then makes absolute neutrophil count of 222 only. So that is marked reduction in neutrophils and neutropenia. There are obviously no sort of circulating NRBCs that I have shown, no precursor cells in granulocytic series. So that is all which you have in this smear. So we move forward and see what next can we do. So before we actually go into the bone marrow, can Priyadarshini actually say what possibilities are here with sort of pancytopenia, relative lymphocytes present in peripheral smear, no NRBCs, and a clinical history which shows no organomegaly, right?
Sir, either aplastic anemia or any viral infection.
Okay, so aplastic anemia obviously remains at the top. Infections causing septicemia. Okay. Sometimes they reduce the counts to a marked extent at very high, at sort of a severe infection. Usually at infections, there's a neutrophilia, and you might see a higher count. But when there is a sort of sepsis-induced low counts, that might happen. You might see organomegaly at that time. Anything else? If the marrow is not aplastic or hypocellular rather than hypercellular. Okay, so we move forward. No worries. Right. Let's see. So for bone marrow, I call Dr. Raina. Let's see what's happening. So that's the aspirate. What do you see at this low power? Anything you can appreciate?
Sir, at this power, bone marrow particles are seen, adipose tissues. If we comment on cellularity, bone marrow see hypocellular.
Okay, so there are two particles,
For this
senior
cell.
small two particles, and they look hypocellular at this bar. In the sort of next slide, also probably the findings are same. There is some variability here, some portion cellular, but broadly they are hypocellular. So we go on the next power for you. So that power basically is to appreciate if there are megakaryocytes or any cell lineage in the trails or maybe along the particles inside the particles. So your comment here would be?
Hypocellular, no megakaryocytes.
So no megakaryocytes are seen here, and the particle again is markedly hypocellular for the age. Remember, it's a young lady there. Okay. So that's the aspirate smears, which are basically hardly any cells, but some scatter cells which you see. So Dr. Tanushri Paul from Dhaka. So can you say what cells are seen here mostly? Dr. Tanushri from Dhaka. Okay. So probably there is some issue there. So we move
Yes,
to
sir.
yeah.
Yes, sir. Sir, there is only adipose tissue. No, no cell is appreciated at this power.
Sorry, probably your voice is not clear, but what I can say is that there are
Sir,
lymphocytes.
having
Yes.
some network issues, can't follow you.
No problem. So we move forward and we say that there are lymphocytes on this power. There are some granular lymphocytes also and a erythroid precursor, a mature appearing the late erythroid precursor. There are no granulocytes. That's an important finding besides the low cellularity. In the next smear, if Tarun Jyoti can comment on this part.
Sir, these look like intermediate normoblasts, maybe.
Okay, I believe these are lymphocytes only, and some of these are the granulocytic, the LGLs. That might be an erythroid precursor. You see, there's some hemoglobinization. The cytoplasm is quite fuzzy. It's not clear, but the blue cytoplasm and these cells hardly indicate their erythroid lineage. The chromatin also is slightly unlikely. That is a monocyte. So the myeloid series, again, the neutrophilic series of cells are hardly there in this smear also. And similarly, in this smear, there are sort of erythroid cells grouped together, some of these, and lymphocytes. So in all, there is a marked depletion of granulocytic or myeloid series of cells in the smears. Anybody to comment? So let Dr. Tanushri Purohit come in and see what cells are here.
So basically, in this field, I could appreciate lymphocyte lineages and macrophage maybe. And in the inset, I can see a mast cell, and the next one is the plasma cell.
Right,
Probably.
good. So these are scattered cells which were seen in this smear. There are some histiocytes, occasional mast cells in this smear, and occasional plasma cells. So in all, we are looking into a bone marrow which has a marked decrease in the myeloid series of cells. They are predominantly lymphocytes. Some of these are LGLs, large granular lymphocytes. Some are the usual lymphocytes, and there are some plasma cells. The AMI ratio probably is around 5:1 with these all there. Right. So let's move forward. We come to the bone marrow biopsy. So again, Dr. Priyadarshini, can we comment on what we see at low power? Dr. Priyadarshini? Yeah. There's some issue in this speaker, if you could manage that. So, okay, no problem. Let's see. So there are basically two cores of trifine biopsy. And, the first thing you look into is whether it's adequate. It's sort of is good enough length, and there are multiple marrow spaces. Usually above 6, 7, 8 marrow spaces are good enough, but if you have more, it's always good. And then you look into the cellularity part. So remember, most of the subcortical spaces might be sort of hypocellular, but here you go deep down. It's a longish biopsy, and most of these are hypocellular for the age of 27 years. This is less than 5%. Yeah. Am I audible?
Yes, sir.
Yes, okay. So, and this part is probably showing some cellularity there, with most of the area covered by fat spaces. So around 5 to 10% cellularity in this part. Again, in this slightly higher power, and you see the similar findings. On higher power, again, at this power, you still might not be able to appreciate the morphology of these scattered cells here. So we might go to the next power, and here there are some islands of these cells. It might be still difficult, but these are mostly the erythroid cells or scattered lymphocytes and plasma cells. So that is what the main composition is in the bone marrow. Remember, when we comment, anybody, how do we assess the cellularity of the bone marrow? How do we comment that's hypocellular or hypercellular, or is normocellular for the age?
Sir, there's a thumb rule that says that we can, whatever the age of the patient is, we can minus 100 minus the age, probably. We can
Right.
calculate
So this
somewhat.
patient is around 27 years, let it be say 25 years, then 75, around 75% might be the cellularity, which means between the intertrabecular spaces, the fat should be just 25% and the cellular part should be around 75%. That's, you know,
75%.
that's, yeah, so that's now how biology works like mathematics, but that's a sort of a way you assess the gross cellularity so that you can make out what kind of marrow it should be there. We'll talk about a little bit on that later also for a few seconds. So we see some plasma cells, some erythroid series cells, maybe some lymphocytes also. The extremely darker ones are mostly erythroids. They are ink dot black nucleus. And those are the eccentric cells, plasma cells. So these are the cells, the granulocytic series, the megakaryocytes are markedly reduced. So overall cellularity is very bad. So just for little sort of theory, the vertebra, sternum, ribs are the ones which reduce their cellularity over time, the minimum. And rest of the long bones and others, they decrease a lot with age. So probably the article does not mention about the iliac bones, which are the preferred bones for aspirate as well as trephine biopsy, but they just follow vertebra probably somewhere there only or a little lower than that. So remember, the gross estimate we take is for these bones. The rest may not be going with the formula. Done. So in this patient, actually, the cellularity should have looked like something like this with age of near 25 years. So 70% cellularity, and this is what this patient biopsy looks like. So overall, we have a pancytopenia with a markedly hypocellular marrow with marked reduction in megakaryocytes and myeloid series of cells. And if you presume, so what would be your diagnosis here, Priyadarshini?
Aplastic anemia.
Right, aplastic anemia. So any differentials here? Tarun Jyoti, let me see. Any differentials?
Mm, hypoplastic.
The
Sir,
bone marrow.
hypoplastic.
So this might be a little interesting. So yeah, so at this cellularity, there are hardly any diagnosis. Anybody?
Sir, hypoplastic MDS.
Hypoplastic MDS is a diagnosis which sometimes you need to entertain, especially if you see some variable cellularity coming up, or even at this cellularity, sometimes it might be possible. So you need to rule that out at low cellularity also, if especially if there is some clinical indications there. How would you do that? Tanushri Paul, is your connection working? Can you differentiate between a hypocellular MDS and aplastic in some case, some as ancillary technique? Okay, we'll move to
So
that
the
also.
reticulocyte count can
Reticulocyte count might be low in MDS again because this is ineffective erythropoiesis.
So in
Aplastic,
hypoplastic
there is
MDS, megakaryocyte can be seen, but not in
megaloblasts can be
aplastic
seen.
anemia.
The bone
okay.
marrow can show megaloblasts in hypoplastic MDS.
Okay, so we are talking about hypocellular. So remember that there are no stem cells in there, hardly any stem cells, precursor cells in aplastic. But in MDS, there still might be. So you can search for stem cells by immunohistochemistry or flow. If they are there, it's unlikely to be aplastic.
30.
The other thing is you can go for a cytogenetic or molecular evaluation for lesions or aberrations which are linked to MDS. Done. So these are two ways, basically, broad ways to sort of look into MDS, which can be hypocellular, rarely though. Okay, so the severity of aplastic anemia can be categorized if the neutrophil count is less than 500, the patient is transfusion dependent, and less than 60,000 reticulocyte, and platelet counts lower than 20,000. That will indicate the severe aplastic anemia, right, at this time. Okay, so I'll give you a little more details. This patient was actually diagnosed outside as severe aplastic anemia, was put on ATG therapy, and may have left it as far as the clinical notes were there in between, and then relapsed and came to the institute. Patient also was known case of Gilbert syndrome and came out to be HCV positive. So remember, HCV itself can cause bone marrow damage at times. So it might be also have an additive effect of reduced cellularity in bone marrow. Right. So the next step, actually, in this case, if we are thinking of aplastic anemia, is coming down to the etiology. That is important, and we'll look into that also. So mostly it could be inherited or acquired. And acquired, we know either can be the idiopathic type, which is the immune destruction type, and or there could be a drugs, toxins, and radiations or other things related, viral infections at times. And immune destruction, which is the idiopathic type, is mostly related to the activity of cytotoxic T cells, mostly CD8s. And some people have gone into details of their functions and probably also look into clonalities in aplastic anemia developing in some of these. Inherited ones, these are just examples: dyskeratosis congenita, Fanconi anemia, and you need to look into some genes, most common being the dyskeratan and others related to telomeres. For Fanconi anemia, the whole complex, most common being the FANC-A gene. There are 22 others probably known for Fanconi anemia, and these are just examples. There are more. So that's a simple flow chart of Blood 2017 article. In the biopsy, you need to still exclude MDS and leukemia, especially the hypocellular types, hypoplastic leukemias also at times. And in aspirate, you can look into cytogenetics for fish, especially to rule out MDS. And you can go into other etiologies of Fanconi anemia. We'll talk about these also later. And when you categorize these as either acquired or the inherited type, you can go into the treatment modalities, which are basically either sort of immune modulatory suppressions or the transplant. So that's the broad outlook I can give. There are more details into it depending on the patients. In this case, usually what happens in aplastic, the patient starts transfusing or has therapies, sort of iron supplements, other supplements being given, and the iron usually is loaded in most of the aplastic anemia at the time of diagnosis. In this patient, there was no pulse. I don't have the photograph for that, but there was pulse 0. So, and when you get a pulse 0 in aplastic anemia, you think of one more diagnosis, which is PNH. And how do you diagnose that, Tarun Jyoti?
Serial dilution.
The modality of diagnosis of PNH these days, at least. Anyone?
Flow cytometry.
Exactly. Good. So flow cytometry is probably the gold standard for diagnosis of PNH. So, there is an association of aplastic anemia with PNH, which might develop synchronously or later or before, even when the PNH clones exist in the blood. So, a little theory, that's the GPA anchor, which is deficient because there is a defect in the gene linked to GPI, that is at XP22 locus. And what happens is any protein which is being anchored by this protein to the surface of cell is deficient. So that is lacking because GPI is not able to anchor that protein on the surface of the cell. These proteins do not have a transmembrane domain. So they anchor by the GPI anchor in the plasma membrane. So how do you diagnose? You either have antibodies against this protein. So if you don't have this protein because of deficiency of GPI, the antibody will not show any availability of the protein because it's not there on the surface. Or you have flare, which actually acts like an antibody for GPI anchor. It actually attaches to GPI directly, and that's the fluorescence aerolysine, which we get from Aeromonas hydrophilia. It's usually genetically modified so that it does not cause lysis of the cells, right? So that's how the flow cytometry looks like. I'll not go into details of it, but basically you get the CD45 viable leukocytes there, and you separate out or identify neutrophils, gate out neutrophils on expression of CD15, which is not GPI linked. So it will be expressed even in PNH patients because it is not GPI linked. And you go for certain proteins and flare combinations. So in this case, the patient had 89% neutrophils, which were lacking in their CD24 expression as well as flare expression. There was some normal also. Similarly, the other lineage we mostly look into is monocytes, which are identified with expression of CD64. So you get out monocytes and see the expression of CD14, which is GPI linked, with flare. So in this case, 90% of the monocytes were deficient in both of these, and there are some normals also left which express 14 and flare. So we have a very large PNH clone. But remember, most of the aplastic anemias do not have a large clone. So you can also evaluate RBCs, which is the antibody used in RBCs. Yeah, Tanushri Purohit. It's already there.
CD55 and CD59.
Right. So you could use 55, 59. Remember the guidelines since probably 2010 or 2012 have said us to avoid 55 because it is not that sensitive. It usually does not catch clones at a very low level. So 59 remains the preferred antigen. So in this case, again, this patient had a large type 3 clone lacking 59 altogether. There was a small type 2 clone also, which had some expression of 59, and then normal normal RBCs, which had normal levels of 59. You could see in the histogram also the type 3, type 2, and the normal RBCs showing enough CD59 expression. So a large clone of PNH in RBCs also, which indicates that patient will be undergoing hemolysis and might have indicators of biochemical parameters which will indicate hemolysis there. So that's another patient, aplastic patient for you, and that's the usual scenario, 0.1% clone of PNH in neutrophils and 0.07 in monocytes. Rest all are normal, expressing 24 and flare. There's one other antigen which is commonly used, which is expressed both in neutrophils and monocytes. Anyone? Rather than 14 and 24. Okay, so that's CD157, which is also being commonly used. The good thing is that it's present both on neutrophils and monocytes. So you can use, instead of 24 and 14, you can replace both of these antibodies and put 157 and see expression both on neutrophils and monocytes. So that's the usual scenario. That low clone in association with aplastic is the usual scenario you see, rather than a high clone. That's usually exception. Any cytochemical tests that you can do in cases of PNH? Anyone? Any cytochemistry on neutrophils? Any enzyme which is lacking? You do it in CMLs? Clue?
Neutrophil alkaline.
NAP score.
Exactly.
NAP
So
score.
the leukocyte or the neutrophil alkaline phosphatase is lacking. So this is not this patient's slide. It shows 2+ and maybe 3+ and 4+ presence of this blue staining granules, which is the neutrophil alkaline phosphatase enzyme. In PNH, you will see nothing here, no blue stain, only neutrophils which are bland in cytoplasm. So that is one thing which is probably. So cytochemistry is going these days because you have flow to diagnose it. And another traditional test, which is the
Osmotic fragility.
Os-
Osmotic
No.
fragility.
No, it's called
CD5.
AMS test. So you see lysis in tube number 5 and 8. I'll again leave the details as theory part, but you don't see lysis. You just see RBC button in rest of the tubes, and 5 and 8 show lysis. So this was a traditional test, very lengthy, very tedious to do, and flow cytometry have removed these tests. So just little theory part there. So with aplastic anemia as the diagnosis, we come to Dr. Rishi to sort of give his perspective. What does he see routinely, and what he expects from a pathologist sitting there? Yeah, please, Dr. Rishi. Should I stop sharing?
So, I was listening to this discussion with a lot of interest, and much of it if you take out some time and ask the patient's attendant or the patient a few questions, it will help you a lot in narrowing down the differentials. And that is where you as pathologists need to stress on properly filled requisition forms for bone marrow aspiration and biopsies that come to you. For instance, if this patient with pancytopenia, if this patient had, a palpable spleen of say 5 centimeters below the left costal margin, the differential will no longer be aplastic anemia. You would be thinking along the lines of, bone marrow infiltration by a lymphoproliferative disease, and then if you look at the temporal history of 3 months, this patient when Dr. Manupdesh, when he showed the clinical history, you noticed it is a fever for 3 months. What are the infections that persist for 3 months and the patient survives those living with those infections for 3 months? Obviously, tuberculosis, yes, but somebody answered sepsis. No patient of sepsis will survive for 3 months. A patient cannot be in septicemia for 3 months. So, those are the inputs that may help you in arriving at a diagnosis with clinical information. Then PNH. So, PNH
Rishi, I will
in
like to intervene
aplastic
there.
anemia
Rishi,
is not
if I offer,
classic hemolytic PNH is usually not seen. It is subclinical PNH or PNH along with aplastic anemia with mild to moderate hemolysis that is seen. A brisk hemolytic PNH is usually not associated with aplastic anemia. So, and existence of a PNH clone in an aplastic anemia, there are data to suggest that these are the patients who do better with immunosuppressive treatment for aplastic anemia. So it is one of the classical teaching is that it is a good prognostic marker in aplastic anemia if you are able to detect a PNH clone. That suggests that the pathophysiology of aplastic anemia is immune mediated rather than an inherited bone marrow failure syndrome. The bone marrow failure syndrome, for instance, Fanconi or dyskeratosis congenita, obviously dyskeratosis congenita will have lot of other syndromic manifestations in form of hairy leukoplakia of the tongue, nail changes, lung fibrosis, liver disease. But Fanconi anemia is one of the inherited bone marrow failure syndrome that can present in adults up to 45 to 50 years of age. So if there is a PNH clone that is detected and the clone size is more than 1%, it is highly unlikely that patient has Fanconi anemia as an underlying cause for bone marrow failure. It is almost always an acquired aplastic anemia or an immune-mediated aplastic anemia that does better. So these are some clinical tips that you will find helpful in narrowing down the differential diagnosis. Always ensure that you get relevant clinical information in terms of history, of duration of history and other associated manifestations, physical examination findings in terms of enlarged or palpable lymph nodes or enlarged spleen, and when you are dealing with when you have aplastic anemia, always stress or there should be a mechanism for reflex testing for flow cytometry for PNH clone. And another important thing is cytogenetics. So that is something I forgot to mention. So, cytogenetics is also important. Please remember that there are, as per the recent WHO 2022 classification, now myelodysplastic syndrome is defined by cytogenetics, and there are some peculiar cytogenetic abnormalities that are MDS defining, like chromosome 5 and 7 and 12 and 11 and 13. So when these 17, when these cytogenetic abnormalities are present, then always think about inherited, concomitant myelodysplastic neoplasm along with aplastic anemia, what we call as hypocellular MDS. So these are some of my inputs on this, and Dr. Manupdesh can go on to the next case. If you have any questions, feel free to interrupt and ask in between or type the question in the chat and I will reply.
Right. Thank you, Dr. Rishi, for your comments. I believe for us diagnosing aplastic anemia and trying to elicit the etiology, because especially the PNH versus idiopathic versus the inherited types, they are important for the management point of view. So if you say PNH, like Dr. Rishi said, the immunotherapies, immunosuppressive therapies or modulators, they help. If you go into the inherited, you will look into bone marrow transplant as the choice. And of course, the prognosis changes because the inherited ones like Fanconi might enter into MDS, leukemias, and other abnormalities, other things also.
And it is very important to make the diagnosis, and along with that, when you write your report, further tests that are suggested by you. If cytogenetic information is not there, write cytogenetics. If PNH info has not been done, advise testing for PNH clone. And there is a emerging role for genomics in aplastica, because please see, what happens is that so why does PNH happen? Aplastic marrow is a soup for clonal evolution, right? Suppose there are 150 students in your MBBS batch and you are intelligent, but you will have a lot of competition to rise with your intelligence, to make a mark in your vivas and examinations. Now suppose I put you in a batch of 50 versus I put you in a batch of 10, or I put you in a batch of 5. Then there are chances that you will start rising above your peers by virtue of your intelligence and case presentation skills and whatnot. Similar thing happens in aplastic anemia. When the marrow is hypocellular, there is chance of clonal evolution. That is why I said PNH is a clonal process. And because the marrow is hypocellular, these PNH clones, they have a survival advantage. Hence, whenever a PNH clone is detected, that means there is an immune-mediated destruction of the marrow. So a PNH clone gains survival advantage and has a chance to proliferate, and possibly, the cytopenias may even partially recover. Similarly, when PNH clone can emerge, why not other clones, other mutated clones? And that is why 15% of aplastic anemia patients go on to develop acute myeloid leukemia or a myelodysplastic neoplasm. And there is a considerable degree of overlap between aplastic anemia and myelodysplastic neoplasm. Hence, it is very, very important that you ask for PNH, ask for cytogenetics, and suggest genomic evaluation, which is at present not as part of a routine diagnostic evaluation, but keep it in the back of the mind that possibly by the time you finish your MD senior residency, these things would have also advanced into the field of day-to-day practice.
Right. Thank you, Dr. Rishi, for your comments there. So we move to the second case.
Excuse me, Dr. Sachdeva, do we take 2 questions now or we take everything at the end?
We can take it, I think.
Yes, the first question is, how can we know in bone marrow define its subcortical space?
Right. So you need to identify the cortical bone. So that it's another sort of a class, but I'll briefly say that the cortical bone is much more thickened. There are a lot of laminations there, and if you see a small, sometimes if the needle has not been inserted and stellate has been withdrawn earlier, you might see the collagen or the soft tissue beyond the cortical bone also. So the cortical bone can be identified by its nature, its thickness, and and anything below the cortex is usually the subcortical bone. When you go down into the medullary spaces, the trabeculae are thin. If they are mature, they are usually lamellated. If there is something activity happening, they might be woven. And then the intertrabecular spaces start with the trabeculae. So usually 1 or 2 spaces below the cortex is the subcortical space. If you go deeper down, you are now into the actual medullary space there. Remember, when we talk about refined biopsy, bypass that pause because it's not relevant to the session. But at low power, once you commit on the adequacy of the biopsy, you look into the trabeculae, the paratrabecular spaces, there is fibrosis, the presence of aggregates of cells, the intertrabecular spaces on the sinusoid. So these are the basic components you always comment, and you might add up as negative sort of findings. The trabeculae are normally thickened, lamellated, they are not woven. The paratrabecular spaces are normal. The intertrabecular space composed, this is the cellularity composed of these cells. So that gives you a rich sort of description of biopsy starting from low power. But that's fine. That's not the topic. We move to the next. Acha, there is another question. Sorry.
Yeah, there is one more. Can aplastic anemia show fibrosis?
Exceptionally rare. So true aplastics hardly show fibrosis. If there is fibrosis in the bone marrow, significant fibrosis, you start thinking of something else, which is not part of fibrosis. Sorry, aplastic anemia. Um, Sometimes if dense fibrosis, myelofibrosis, primary or secondary, can lead out to dense fibrosis and a look which is totally hypocellular. So remember, aplastic anemia, idiopathic, familial, is hardly show any fibrosis. If it is there, you probably put the aplastic diagnosis little down and start considering something else, evaluate more. Yeah, that's it.
Yeah. There's one more question, which is, should we suspect PNH in hypoplastic marrow of adult patient?
Sorry, again,
Should
please.
we suspect PNH in hypoplastic marrow of adult patient?
Why not? PNH is a disease of adult patients. And hypocellularity is very often associated with PNH. Although marrow can be very, very cellular, it can be at times rarely hyper also, depending how much is the hemolysis taking place in a frank PNH clone there. But hypocellularity in adults is associated with PNH. PNH is rare in children below 10 years. So it's a diagnosis of young people and often associated with the aplastic. If not often, associated with the aplastic at times. Right.
Okay.
So I would rather thinking of the previous question also, radiation injury sometimes induces hypocellularity with fibrosis. So that's one condition, but again, it's not a sort of a true aplastic condition. Yeah, please. Yeah. Anything else?
No, we don't have any.
You need to ask in history is whether the patient is having exposure to benzene. And patients who work in the petrol pump, in the automobile industry, they inhale a lot of benzene vapors. And benzene is a highly lipid soluble. It crosses the pulmonary vasculature, enters the systemic circulation, and is myelotoxic to the bone marrow, hematopoietic stem, and progenitor cells. So that is one helpful part of history. Second helpful part of history is premature graying of hair, less than 30 years of age. And that is important. That is telomeropathies. You need to suspect telomeropathies. Family history of relatives dying with pulmonary fibrosis and liver fibrosis, even though they are not very voraciously alcohol consumers. And mild to moderate alcohol intake, developed liver cirrhosis, died because of liver cirrhosis, even though not very enthusiastic alcohol consumers, premature graying of hair, less than 30 years of age. You should always ask the history, do you dye your hair? And if they say yes, then when did you start having gray hair, less than 30 years of age? Telomere disorders. That is another cause that manifests in adult age with aplastic anemia.
Can we move to the next case, I think?
Yes, sir.
Right. So case 2, I'll ask Tanushri Purohit to come in. I'll just read the basic history. So this is 35-year-old female, again young patient, and the patient had easy fatigability for 2 months. On examination, there is pallor and mild hepatomegaly. Again, there is anemia, moderately severe anemia rather, and some lowering of leukocyte count. Platelets are just mildly reduced. So pancytopenia again. And we come to the peripheral smear. That's too low power. We will shift to the next smear. So you can comment here about the, yeah, please.
So at this power, again, we can see that leukopenia can be appreciated. And if I see there is mild anisopoikilocytosis, which I can appreciate some pencil cells and a neutrophil. Probably in the next slide, we can see the segmentations, how many segmentations there. But at this level, I can see a neutrophil and a lymphocyte and some pencil cells, and probably a red cell mass has been reduced overall.
Right. So basic findings here is that the leukocyte counts look lower side and there is a red cell mass which is reduced. The cell sizes look a little different,
Different.
smaller or larger or whatever. So that's the basic finding at this part. Now we come to the oil emulsion and you can describe the morphology of the cells.
So in this, basically, hypersegmented neutrophil can be seen along with, if we see the RBC, the teardrop cells are seen. Few of them, maybe an isopoikilocytosis again can be appreciated. And again, we can see platelets, but not that reduced. In this field, I can see moderate platelets, and then in hypochromic RBCs are also seen.
Okay, so maybe we'll move to the next smear. You are right. Most of the there is an HSP there, hypersegmented polymorph with probably 6 lobes.
Yes.
And you see some anisopoikilocytosis. Probably I'll call it moderate anisopoikilocytosis. Platelet looks good in this smear. You can have 7, 8 lobed also in this patient. This is not from this patient. So at times hypersegmented polymorphs can be very prominent.
Yes, sir.
Right. So yeah.
So on this 100x, we can appreciate now by comparing the lymphocyte size, we can say that some of the macrocytes are seen, macrovelocytes are seen, teardrop cells, and few of the normocytes as well. And there is hypochromia, and the RBC mass has been reduced.
Okay, so yes, there are macrocytes, there are large cells, there are some macroovelocytes also. They look larger than lymphocyte there, and many normocytic normochromic cells. That is true. Yeah, so some odd poikilocytes, teardrops, and some of this.
Schistocytes.
Yes. Yeah, so some poikilocytes there, I believe. And that is the differential count in this patient: 53 neutrophils, 37 lymphocytes, 9 monocytes, and 1 eosinophil. So difference from the previous patients is that the neutrophils are fair enough in this differential, right? And you predominantly also see that there is definitely some amount of macrocytosis. So, so what diagnosis at this stage, if I ask?
Probably can be megaloblastic anemia.
So thinking of megaloblastic anemia, you can definitely say about the macrocytic anemias.
Macrocytic anemia.
Yeah, so megaloblastosis.
Macrocytic.
So what is the pointer towards megaloblastosis in this smear? There are pointers.
So basophilic stippling is seen. Probably.
Oh, avoid. This is not in this patient.
Okay.
I did not show you this.
Okay.
Okay. Right. Okay. Any other pointer? You described in your RBC morphology also and in your leukocyte morphology also.
So hypersegmented neutrophil and
Exactly.
macrocytes were seen and macrovelocytes were seen.
Right. So two things. Remember, HSPs are very often associated with megaloblastic anemia rather than most of the non-megaloblastic macrocytic anemias.
Yes, sir.
And macroovelocytes are also more often associated with megaloblastic bone marrow rather than macrocytic anemias per se. So they are just soft pointers. They are not very specific, but yes, more often associated with a megaloblastic marrow rather than. You might also see some basophilic stippling if not seen in this patient. The red bordered slides are not of this the patient index patient in any of my presentation, right? You might also see circulating megaloblasts.
Megaloblast.
Right.
Yes,
So occasional nucleated RBCs, although radiculocytosis is usually low in a frank megaloblastic patient. Till the time the patient has started a treatment, they are usually low, the radiculocytes. You might see circulating NRBCs at times.
NRBCs. Yes, sir.
Right. So in this patient, there is moderate anisopoikilocytosis, macrocytes, macrovelocytes. The platelets are somewhat reduced, mildly reduced, and you see hypersegmented polymorphs. Before asking any other thing you want from me, I've already displayed that this patient had indices like this.
Yes, sir.
So there is, can you sort of interpret the indices?
So MCV is more than 100. That interprets more towards the macrocytic anemias,
Right.
and the RDW showing 22. That means it's moderate anisopoikilocytosis. The shapes about.
Right. Probably MCH is also a slightly higher side.
Slightly higher
So,
side,
yeah,
yes, sir.
so that
Hypopenia,
indicates
yes.
a macrocytic picture with
Picture.
anisopoikilocytosis.
Cytosis.
And the reticulocyte is not responding to the amount of anemia of 6
Anemia, yes, sir.
right? So, okay. So we have already, sorry, you say echo again, so somebody needs to shut down some other mobile or something else. So we have already talked about the basic diagnosis there. We move to the marrow rather than discussing more here. So let Tarun Jyoti come in for bone marrow aspirate smears. So at LOPAR, anything you appreciate? 37-year-old female, Tarun Jyoti.
Sir,
At this par, what would you probably comment and appreciate of bone marrow aspirate?
the cellularity.
Okay, so it's particulate. Do you see a particle?
Yes, sir.
Yes, so there is a particle and which looks quite cellular, but I will comment on this on slightly higher part that this is a sort of a clotted particle. It's not as good as it should be. So clotting has started in the procedure of bone marrow there. Probably there's a delayed smearing or the patient has some sort of early clotting activity. At this part, anything else you would like to comment? So usually we see megakaryocytes at this part. Cellular trails. Yeah.
Yes, sir. Trains are there.
Okay, so what I would like to know is that the particle is still there. It's looking hypercellular, but once the clots set in, the cellularity may not be commented because it might look falsely high also. There are hardly any megakaryocytes, but the trails are cellular. It's still showing cells. Remember, when the clotting starts, the megakaryocytes tend to get entrapped in the particles, so they might be factitiously low. So remember that part also. At slightly higher part, okay, so we move to the more, that's the megakaryocyte I've pointed out for you. There were not much there because of clotting, and we might move on the morphology. So here, Tarun Jyoti, so what do you see here?
Sir, erythroid precursors are seen.
Okay, so these are likely to be erythroid precursors. What stage of maturation? Are they early, they are intermediate or late or what?
So they're early normoplasts, probably.
Early erythroblast, right. And these cells, the other cells?
These look like of myeloid lineage.
Right. So you see both erythroid lineage cells and myeloid lineage cells in this power. Okay, going into the oil emulsion, you can appreciate the morphology. So you see a lot of these early erythroblasts, and you might also see the intermediate forms of erythroblast where the chromatin is slightly more condensed, right?
Yes, sir.
And any comment on the myeloid series of cells? Okay, you see enough neutrophils there,
Yes, sir.
and these are
Band forms.
these are band forms, right? And they appear slightly larger, I believe, than usual neutrophil size. The neutrophils as well as the band forms appear slightly. The metamyelocytes appear larger. So I don't say they are really giant band forms or giant metamyelocytes, but they are slightly larger in this case. So we see a lot of erythroid cells, mostly precursor. The other important observation is that in usual marrows, the late forms. Yeah, so again there is echo coming up. So in usual marrows, the late forms of erythroid precursors are the predominant population. The early forms or intermediate forms are less in percentage when you add up all erythroid precursors together. So here in these pictures, I don't see too many late or maturing mature or erythroid precursors. So hardly any hemoglobinized erythroid precursors are seen. So that's another observation to make. Similarly, here they are sort of band forms which are large in size. And there are erythroid precursors. That's the one which is slightly late. You see there is a polychromatophilic like cytoplasm, somewhat hemoglobinized, somewhat cell blue, and still opened up and larger. So overall, again, a lot of erythroid precursors. They are large sort of polymorphs and large band forms. Okay, and that's the differential you get. So there are 40% erythroid cells And the myelocytes, metamyelocytes, neutrophils, they form another part, and there is the erythroid is to myeloid ratio is around 1:1. So there is slight erythroid
Reverse.
prominence there with a megaloblastic look in marrow. So now if you have a megaloblastic hypercellular marrow, this looks easy, but this can be nightmare for hematopathologists in cytopenias, because there are a number of conditions which look like this, and you rule out them. So any DDs come up? Tanushri, Paul, can you please come in and tell me if there is a megaloblastic sort of?
Sir, yes, sir.
Yeah.
Megaloblastic anemia.
Okay.
Yes.
Anything else which can?
It could be due to vitamin B12 deficiency, pernicious
Right.
anemia.
Right. So that's all megaloblastic anemia you're tackling. Any other condition will
Yes, sir.
have hypercellular marrow, cytopenias with erythroid prominence, maybe megaloblastosis coming up?
No, myelodysplastic.
Liver
No.
disease.
MDS. So right. So the MDS can again look like
Okay.
something like this, although the megaloblastosis may not be as severe as in severe megaloblastic anemia. There might be a lot of mature late erythroid precursors also at times. Okay. Anything odd in clinical aspect? This patient is young, right? So MDS in younger patients you see off and on. It's not exceptionally rare, but obviously it's more common. The mean age probably is 60 years or somewhere there. So it becomes as a second diagnosis. Anything else? Megaloblastic erythroid hyperplasia. So if the erythroid hyperplasia was like 10:1, the 1:10, a lot of erythroid precursors packing the marrow. No leukemias can look like that.
Yes, sir.
Anyone? 80%, 19%, 90% erythroid precursors, mostly megaloblastic. Okay, so erythroleukemia is another
Erythroid leukemia.
diagnosis with cytopenias coming up at times. Usually you might see it's another mostly in elderlies, and you might see organomegalies coming up. So in this case, there were no there's a mild hepatomegaly, but not large spleen or anything else, and the patient is also young. But remember, it's another diagnosis, and if the erythroid hyperplasia increases with such cells, blastic cells coming up as predominant cell population, erythroleukemia is another diagnosis which complexes us. So it sometimes megaloblastic anemias look easy, but they can be very difficult real life situation at times. Okay, so we move ahead. We go to trifine biopsy. So let Dr. Raina come in for trifine biopsy. At low par, any comments?
Sir, it looks like hypercellular.
Markedly hypercellular for the age. Remember, the age is 35 years, and you must see around, say around 50-60% cellularity there with fat spaces. So there's hardly any fat space, right, in this. There's a packed marrow. So I would rather say a markedly hypercellular marrow at this par also. Rather, the only thing you see here, non-cellular, is the dilated sinusoids. There's hardly any fat. So we move to next power. Here, anything else which you can appreciate at this part? It's 10x.
Sir, megakaryocytes.
Right, exactly. So you see some megakaryocytes at least. Right. So they are there at this part. You start seeing megakaryocytes, still cellular marrow. And the darker islands, any comment on this at this part? Might be difficult. But the darker cells here? Okay.
The erythroid.
Erythroid precursor.
Yes, they're likely to be erythroid. So yes, so that's this part. I think it's hypercellular. You see megakaryocytes, which are probably adequate in numbers, and there are some darker cells which might be erythroid. They exist as islands in bone marrow, right? So yes, Dr. Anna. So a little more morphology here. Anything to add up?
Sir, in erythroid precursor, mainly early erythroblasts are seen.
Okay, so there is marked erythroid hyperplasia. That is how I'll define. And the paler cells are early erythroids, correct?
Early.
And the darker cells probably are the intermediate forms or the late forms, right? So most of the cells seen here are of erythroid lineage, a little on the higher part, and you see these blastic appearing cells, which possibly are of erythroid lineage. There are certain soft pointers which can indicate and differentiate it from the other cells. it might be difficult on section, but since you already have an aspirate to give you a supplementary information, you know you are dealing with erythroid precursor rather than any other blastic appearing cells. And you see mitotic figures very often. So there is erythroid hyperplasia, marked erythroid hyperplasia, maybe more than what you saw in the aspirate itself. Right? And most of these, correctly said, are the early erythroids and some are the late, intermediate or late. So another photomicrograph, similar. Any way to identify erythroid precursors, early erythroid precursors, and differentiate them from myeloid precursors or any other blasts?
Sir,
Sir,
in
we
the
have,
erythroid precursor, the nucleoli are attached with nuclear membrane.
Oh, good. Excellent. So that's again a sort of soft pointer there. It's not absolute, but correctly said. Usually they have elongated nucleoli, and many times it is attached to the nuclear membrane. It just depends on what orientation the section is being cut. But many of these, if well oriented in the way we want to see them, you will see that the transverse elongated nucleus attached to the membrane. If they are cut like this, obviously these nucleoli will be seen as a dot. So that's a soft pointer there that they might be erythroids. And then the cytoplasm is more amorphous. Sometimes the genuine myeloid precursors might start showing dots, the later type sort of blast where the granularity appears. Yeah, okay. So we move forward to the next slide. Good. Right. So similar findings there also. So I add up some information. This patient also had continuous fever for some time. There are, of course, cytopenias, and clinically, the bone marrow request form came for to rule out tuberculosis and hematological malignancies, since there was also a little hepatomegaly there. So we had megaloblastic erythropoiesis with marked hypercellularity. And we have already discussed the cells. So this is another patient. You see the red border there. This is a very recent patient, and we still don't have the diagnosis because this patient also has some organomegalies. You see how predominant is the erythroid population. There is some dysplasia also coming up in erythroid series, but around 10% or around that dysplasia might be seen in severe megaloblastosis also. And then there are giant sort of metamyelos coming up. So pure megaloblastosis versus erythroleukemia is still a diagnosis to be made in this patient. Remember, if you get a clinical history, that patient has already been given B12 folate, an adequate supplement, including iron. Sometimes there's dual deficiency and the response might be limited in that scenario. Or even if you say that the oral might not be effective due to a number of causes of sort of vitamin B12 or folate deficiencies, which might affect intestinal absorption. If the clinician tells you that the parenteral sources have also been tried, and including transfusions. Remember, a transfusion, single or maybe two transfusions might be enough. A single transfusion might be enough for a dosage of B12 and folate to show you a response, reversal to a normoblastic picture in some due course. So in that scenario, the likelihood of not being a megaloblastic anemia is there. So that input is very important. And in any case, if you have confusion like this case, which is very recent, you can still give a trial for B12, right? So that's just a picture to show normal, early, intermediate, and late. That clump should be there with hemoglobinization. That's the megaloblast, early megaloblast. The late sort of erythroid cell, which is showing opened up sieve-like chromatin, and the hemoglobinization is adequate. So that is how the megaloblast will look like. If this megaloblast is severe, you stop seeing the late forms, and there's a rest of maturation. You start seeing the earlier forms more often in the bone marrow. Okay, so those are the usual findings in peripheral blood. That's just theory. You can read it off: macrocytosis, oval macrocytes, teardrops, segmentation, hypersegmentation, and some other findings. Bone marrow, of course, hypercellular, erythroid hyperplasia, megaloblastosis, some amount of dyserythropoiesis might come off, giant metamyelos, band forms, increased histiocytes because of cell death, ineffective hematopoiesis. So again, theory, B12, folate, there might be causes of food, stomach, intestine, drugs, and various causes. So I mean, we can go through that, but that's not the purpose. We are more towards how to differentiate between one thing or the other. Folate, again, there might be nutritional causes, malabsorption, some drugs, some growth stages, infancy, pregnancy, malignancies where absorption, utilization of folate is very fast, tropical sprue, gluten sensitivity, some drugs which cause folate deficiencies, and they are rare causes like say thiamine sensitive responsive sort of megaloblastic anemia and some other rare causes. So I stop here. We in our practice, when we see a cytopenia with erythroid hyperplasia with megaloblastosis, maybe minimal or mild to moderate or severe even, there are diagnoses which can trouble you as pathologist. MDS needs to be ruled out. Erythroleukemias might become a diagnosis. We have seen misdiagnosis of hematosplenic gamma deltas, which present as hypercellular marrows, erythroid hyperplasia, some amount of megaloblastosis. They get diagnosed as megaloblastosis and or ITPs because there's thrombocytopenia, some hematomegaly, splenomegaly, and the odd sort of diagnosis which come into picture, and it becomes troublesome to report megaloblastosis per se because usually the patient come with some sort of treatment, right? So yeah, so let Rishi come in at this stage, his perspective with clinical picture in this case or clinical issues.
This is a it appears very straightforward, but it is a very tricky diagnosis for a hematopathologist as well. And if you just do a PubMed search, you may find some old papers saying that these patients have even been evaluated and undergone a bone marrow transplant as well, because they got misdiagnosed as myelodysplastic neoplasm. So many times in the clinic, I also tell the patient if they have a mild to moderate anemia, not yet requiring transfusion, some macrocytosis in the smear, take a trial of injectable B12 and come back and see me after 2 weeks. By the time we give an appointment for a bone marrow examination and other things, and occasionally they come back after 2 to 3 weeks that we have undergone a marrow examination, but now our complete